بسم الله الرحمن الرحيم. السلام عليكم جميعا. Thank you, Dr. Abdurrahman, for the introduction. So I'll be talking today about portal vein thrombosis in cirrhotic patients. And as you know, this is one of the common findings in patients with decompensated liver cirrhosis, yet there is no clear guidelines in regard how to manage such a clinical problem. So as introduction, the portal vein is a vital structure providing 75% of the blood supply to the liver. And anatomically, it originates posterior to the pancreas by the confluence of the superior mesenteric vein and the splenic vein. So what's the incidence of the BVT? BVT is considered the most common thrombotic event in cirrhotic patients, and the cumulative incidence parallels the progression of liver cirrhosis, being the most common, being less than 1% in well-compensated cirrhosis, and as common as 25% in liver transplant candidate. Regarding the clinical presentation, majority of patients with BVT are asymptomatic and discovered incidentally during routine surveillance ultrasound for hepatocellular carcinoma. In some studies showed that those patients might present with higher risk of variceal bleeding, with difficulty to control the variceal bleeding during endoscopic therapy. Interestingly, the majority of BVT with cirrhotic background are non-occlusive, and therefore the portal cavernoma is rare finding in those patients compared to non-cirrhotic portal vein thrombosis. What are the risk factors? There is no risk factor there is no single risk factor that you can blame. Rather, it's multifactorial. And the most commonly accepted pathogenic driver is a change in the portal hemodynamics due to increase in the intrasinusoidal pressure, leading to significant reduction of the portal vein velocity. The prevalence is very much correlated with higher MILD score and higher Child-Pugh score, and NASH by itself considered as a prothrombotic event in compared to other etiology of chronic liver disease. Any role for hypercoagulable state on those patients or any underlying pathophysiology on those patients? Some studies is reporting that prothrombin gene mutation can be detected in around 10% of those patients. However, hypercoagulable state is not a routine workup in patients with in portal vein thrombosis with cirrhotic background. So how do you classify the portal vein thrombosis? The portal vein thrombosis can be classified in different ways. Can be classified according to the timing of the presentation into acute versus chronic. However, this classification is not very helpful in routine clinical practice since majority of patients are asymptomatic. And it can be classified radiologically according to the degree of the occlusion of the main portal trunk into partial versus complete. And the most useful classification is according to the degree of the occlusion of the portal vein and the extension of the thrombus into mesenteric vessels. The most widely accepted classification is the classification proposed by Yerdel and his group, and they are classifying the portal vein thrombosis in cirrhotic background into four grades. Grade 1, when the thrombus is minimally or partially occupying the portal vein in less than 50% of the vessel lumen with or without minimal extension. Grade 2, when the thrombus occupying more than 50% of the portal vein trunk with or without minimal extension into superior mesenteric vein. Grade 3, which describing the thrombus occupying, the thrombus is with complete thrombosis of the portal vein with proximal extension into superior mesenteric vein. However, the distal superior mesenteric vein is open. Grade 4 is when the thrombosis is occluding the portal vein and proximal as well as distal superior mesenteric vein. And Yerdel grade 3 and 4 representing a major challenge during liver transplantation. So what is the clinical impact of the portal vein thrombosis? So this is a very controversial topic and full of debates. I am going to discuss it from two different aspects. The first aspect is the clinical impact of the BVT on the natural history of liver disease in general. And the second aspect is the clinical impact on liver transplantation. So I'm going to share with you some of the studies that address this question. The first study is interventional randomized controlled trial, included patients with a child B and C chronic liver disease, and they divided them into two groups. The first group received prophylactic dose of enoxaparin, while other group did not receive any specific treatment. The endpoint of this study is portal vein prevention. As you can see in the diagram, in the first diagram on the left, that the probability of the BVT during administration of enoxaparin is 0 in enoxaparin group, while it is significantly different from those patients who did not receive enoxaparin. Furthermore, the probability of decompensation is much less in enoxaparin group in compared to those who did not receive enoxaparin. And the probability of the free survival, liver transplant survival, is much better in those who received enoxaparin. From this study, we can get indirect evidence that prevention of the BVT might prevent liver decompensation. However, with all this remarkable finding, it is hard to explain it just by prevention of the portal vein thrombosis. The other explanation that enoxaparin might slow the progression of the liver disease and slow the progression of the portal hypertension. This study should be reproduced in other larger studies to confirm the finding and also to think about adopting such strategy in patients with chronic liver disease. Second study addressed the natural history of portal vein thrombosis from radiological point of view. This study includes 42 patients with cirrhosis and untreated portal vein thrombosis, and those patients were followed over a period of 27 months, and interestingly, around 50% of those patients, they have spontaneous recanalization of the portal vein without any specific treatment. This is one of the largest, if it is not the largest study done to address this question. This is a prospective longitudinal study, included more than 1,000 patients with a child A and B chronic liver disease. And they concluded from this study that BVT was associated with severity of liver disease. So it is a marker of severity rather than a cause for further liver decompensation. And 85% of those patients had non-occlusive portal vein thrombosis. And they concluded clearly in this study that no evidence that BVT is responsible for further progression of liver disease. So we can summarize the impact of BVT on the natural history of liver disease by the following points. Again, it is still a very controversial topic, many contradicting studies. And we can say it is likely that prognosis of cirrhosis with BVT will be influenced by not only BVT by itself, however, it's by the degree of the occlusion of the venous system and the clinical situation of the patient at the time of liver transplantation. So what is the impact of the BVT on liver transplantation? BVT represents a major technical challenge to the hepatobiliary surgeon during liver transplantation. And the approach to the BVT during liver transplantation can be simple as just a thrombectomy during liver transplantation to more complex vascular reconstruction during liver transplantation. It has been shown in multiple studies that occlusive portal vein thrombosis at the time of liver transplantation is a predictive of short-term mortality after liver transplantation. Knowing this, what is our aim in a patient who is a candidate for liver transplantation? Our aim is to have recanalization of the portal vein to allow conventional end-to-end anastomosis before liver transplantation. And if this aim cannot be achieved, our next aim is to prevent extension of thrombus into superior mesenteric vein. The first strategy to have recanalization or to prevent thrombus extension is by anticoagulation. This table represents majority of studies done to address this question. As you can see, the type of study ranging from prospective to retrospective studies, the number of patients are really small, and the most extensively type of anticoagulation used in these studies is low molecular weight heparin. I am not going to in details of this table for the sake of time, but I am going to concentrate on the role of direct oral anticoagulation in patients with chronic liver disease. We have two types of DOAC. The first one is factor 10 inhibitor like rifaxiban and apixaban, and the second group is directed thrombin inhibitor. The advantage of this group of medication that can be given orally without a need to monitor the INR or APTT. But unfortunately, we have a limited evidence to support routinely using this medication in patients with chronic liver disease. Other drawback of this medication is they are not recommended to be used in child B and C chronic liver disease, and there is no specific antidote for this medication till this time. This is a meta-analysis published recently in Gastroenterology, evaluated the safety and efficacy of anticoagulation in patients with BVT with cirrhotic background. The rate of recanalization favors anticoagulation group over no anticoagulation. As you can see, the diamond is crossing 1, and the risk of variceal bleeding. Conversely, it has been shown that anticoagulation is protective against variceal bleeding. However, the sample size of this meta-analysis preclude definitive conclusion. So I can summarize the role of anticoagulation in patients with BVT with cirrhotic background in the following points. Multidisciplinary approach is highly recommended between the gastroenterologist and the hematologist. Caution should be advised with all types of anticoagulation by adopting primary and secondary variceal bleeding, a prophylaxis for variceal bleeding. DOAC cannot be routinely recommended in those patients. And other important point is the timing of initiation of anticoagulation is important predictors for success. It has been shown in the studies that if you start anticoagulation in less than 6 months after diagnosis is associated with higher likelihood of recanalization. So is there any other strategy to treat those patients before liver transplantation? TIPS is an evolving method to be considered in those patients. This studies included around 50 patients with yearly classification grade 2 and 3, and all of those patients were candidates for liver transplantation. As you can see, the patency of portal vein thrombosis 6 months after insertion of TIPS is reaching up to 100% in those patients with partial portal vein thrombosis, and 85% on those patients who had complete portal vein thrombosis. This type of procedure requires high level of expertise in your institute. So now what the guidelines said regarding this topic, as I mentioned before, there is no clear consensus or guideline. The most recent recommendation coming from a Bavino consensus workshop stating that anticoagulation should be considered in a potential candidate for liver transplantation. And in untreated potential liver transplant candidate with BVT, you need to follow your patient with imaging to look for extension of the superior mesenteric vein thrombosis. And if there is extension, then you need to consider anticoagulation on those patients. In non-liver transplant candidates, there is no recommendation can be made at present. And you need to consider the anticoagulation on case-by-case basis. So I'm gonna conclude or summarize my talk by suggested algorithm, which I quoted from different article with some modifications. So if you are dealing with patient with portal vein thrombosis that detected by ultrasound, you need to confirm the diagnosis by contrast enhanced study, either CT scan or MRI, and to rule out possibility of HCC as a major cause of portal vein thrombosis in cirrhotic patients. So if your patient fitting in any of these categories, either non-occlusive portal vein thrombosis in non-liver transplant candidate, or your patient is decompensated not on liver transplant list, or there is a clear contraindication to anticoagulation, then anticoagulation is not considered at present time. However, you need to follow your patient with ultrasound every 3 to 6 months to re-evaluate the status of portal vein thrombosis. On the other hand, if your patient is a candidate for liver transplantation, or if there is extension into superior mesenteric vein, or your patient is presenting with symptom and sign of bowel ischemia, then anticoagulation should be considered in those patients. And you need to repeat the imaging every 3 to 6 months to follow the status of the BVT thrombosis. If there is a BVT progression or there is a major bleeding event contraindicating the anticoagulation, then TIPS can be considered in those patients as a salvage treatment. If there is a BVT progression or stability of the thrombus, you need to maintain anticoagulation until the time of liver transplantation or indefinitely. So I'll conclude my talk by the following point. BVT is a common finding in end-stage liver cirrhosis, is uncommon in well-compensated cirrhosis, and the causal factor is considered as epiphenomena rather than primary phenomena due to increase in the intrasinusoidal pressure. It is considered a marker of severity, and it is very much correlated with higher MILD score and higher Child-Pugh score. Is it a cause for aggravation or further decompensation of liver cirrhosis? Still, the question is open for further research. And the strongest indication for anticoagulation is candidacy for liver transplantation. And thank you for your attention.